Good afternoon, respected judges and chairperson and colleagues. So, I'll be presenting to you a new device for amniotic membrane cover in ocular surface burns and SJS. I have no financial interest in the matter. So, we know that the amnion part of the placenta is of great interest to the ophthalmologist, and of that we are particularly interested in the basement membrane and the stroma, not so much in the epithelial cells, because the basement membrane and stroma has got properties which modulate stromal scarring and is anti-inflammatory. The uses of amniotic membrane is mainly in reconstruction of the ocular surface in the presence of after pterygia excision, bullous keratopathy, partial limbal stem cell deficiency, etc. And more importantly, in conjunction with limbal stem cell transplantation, as in SLET or CLET. However, amniotic membrane is a game changer in acute chemical burns of the ocular surface and acute Stevens-Johnson syndrome. So, we know that in grade 4, 5 and 6 of Dua's classification, amniotic membrane transplantation is strongly recommended after chemical injury. However, Stevens-Johnson syndrome is a completely different animal in which the patient is usually so moribund and on life support that even touching the skin causes bleeding, and there is denudation of the epithelium, goblet cells, stem cells from the palisades of Opht as well as from the mucocutaneous junction of the lids. Gregory's grading, published in 2016, shows that in severe and extremely severe variety of SJS, amniotic membrane transplantation should be done within 48 hours of the detection of the disease. The conventional technique of doing amniotic membrane is to place the amniotic membrane on the skin of the lids and then tuck it in and suture it to the lids either separately or including the fornices in the suture, or alternatively one could place a conformer and then suture it to the lids. Whatever it is a back-breaking procedure, takes a lot of time and requires sutures. There are also devices like Procera, which has a lyophilized amniotic membrane on a polycarbonate ring, and unfortunately this gives a coverage of only 1 to 2 millimeters beyond the cornea and beyond the limbus, and is not available in our country. Some people also use infant feeding tube, which is coiled on itself and pushed into the fornices to maintain the amniotic membrane over there. So, we felt that there was a need of a new device which could be assembled in the eye bank or in the OT ready for use. It could be stored like a regular amniotic membrane and could be inserted under topical anesthesia at the bedside in a matter of minutes. So, with that in idea, we started designing this device, and we went from an open C loop design to a closed loop design. The idea of the open C loop design was to make it conforming to different sizes of fornices. However, this is the final design of a two-part amniotic membrane inserter that we arrived at. The bottom part has a notch onto which the top part snap fits, and the assembled device is fairly pliable so that it can conform to fornices of different sizes. The bottom part is slid under a amniotic membrane, and then the top part is snapped in. In this manner, it just becomes like a contact lens which can be used at the bedside. So, here are some usage videos in which you can see that this device has already been assembled and is being inserted at the bedside under topical anesthesia. So, it's that simple, and it really reduces the surgical time. Here is another usage in acute SJS in the ICU, where it is being assembled on site on the surgeon's assistant's gloves. And the advantage of using a larger amniotic membrane that you can see over here is that it can be brought out from the fornices after inserting the device and can be used to drape the lid margins, because as we know, in acute SJS the lid margins are also severely affected. So, this is now available commercially from Orolab, although I do not have any financial interest in it. And here are some results. This was a 13-year-old girl, in which you can see the 14 days post-op. You can see the AMserter in the fornix, and you can see that the eye has already quietened down significantly. This is a alkali burn with a delayed presentation, in which AMserter was put in the OPD using the slit lamp, not even in the OT. And this is a case of a Chuna injury in which there was considerable conjunctival necrosis, which was debrided, and then these are the results. the results are just like any other amniotic membrane transplantation technique, but the usage is far easier. So this is a acute thermal burn, and the picture on your right shows the extent of cover that this device gives, and the fact that it goes into the fornices prevents seminiferin formation as well. So the advantages of this device is that it is elliptical design which conforms to various shapes of fornices. It is deformable with good memory and is not too brittle. You can mount an extra bit of AM, larger AM to drape the lids. We have used up to bilayers, and we are working on incorporating multiple layers of amniotic membrane on the device, and we can also apply glue on the undersurface and put it in. However, the need remains to educate the critical care specialists and dermatologists so that these cases are referred early to us. Thank you.
A good technique. Dr. Bhaskar, at what stage you feel that we should adopt this procedure?
Amniotic membrane device. This is for the very acute stage. Like Stevens-Johnson syndrome, the recommendation is to do it within 48 hours. So after this device has been available commercially from around September last year. So the usage scenario is gradually expanding. So people have used it after ocular surface reconstruction from tumors, then for persistent epithelial defects. So the device just makes it easy to insert the amniotic membrane in a sterile manner and reduces your surgical time drastically. Any form of amniotic membrane use. So not particularly what area you are going to use it, but primarily it was designed for acute SJS, and in acute SJS it should be used within 48 hours.
Any specific post-op medication in your cases?
Post-op?
Medication, topical or any?
Post-op medication will depend on the disease. Like in acute SJS, you will definitely give antibiotic and steroids. There are a few issues which are coming up now, like if the membrane that is being attached, if it is too redundant, there is a lot of space, then debris and fluid tends to collect over there. So that is true with sutured amniotic membrane also. So it has to be kept in mind that the membrane has to be fairly taut on the device so that it goes and conforms to the ocular surface properly.
And what is the incidence of failure or unsatisfactory results in your cases?
Sir, abhi tak to nahi hai. Not till now. Usually, like any other amniotic membrane, if the amniotic membrane dissolves, you take out the device. Device can be taken out very easily because you saw in the picture that it is visible in the lateral canthus. So you can just push it out like a contact lens or grab it with a forceps and take it out. So as long as the amniotic membrane is there, you can keep it. Otherwise, you keep it for 2 weeks is the usual time after SJS, and you can reinsert a new one. Thank you.
Thank you. Thank you. So next.